Hello, and I welcome you on behalf of my team of residents from Mount Sinai Medical Center to our presentation on our QI project, which is optimizing management of iron deficiency in patients with heart failure with reduced ejection fraction. This is a quality improvement project at our hospital to improve outcomes for patients admitted with exacerbations of heart failure with reduced ejection fraction who have concomitant iron deficiency with and without anemia. The study design consists of comparing resident practices before and after a didactic intervention to our entire residency class in the form of a presentation, and also demonstration during this presentation of data and guidelines regarding iron deficiency in heart failure. Our intervention is backed by randomized controlled trials, namely the FAIR-HF, CONFIRM-HF, AFFIRM-AHF, and IRONMAN studies. These studies have shown that IV iron supplementation in patients with HFrEF and concomitant iron deficiency with and without anemia, the prevalence of which is 37 to 62% in all HFrEF patients and 60 to 80% in patients with acutely decompensated HFrEF, is associated with improved outcomes in 6-minute walk tests, NOIHA class, peak VO2, congestive heart failure hospitalizations, and cardiovascular hospitalizations. These results are reflected in AHA and ESC guidelines for congestive heart failure, where IV iron replacement for HFrEF patients with iron deficiency remains a Class 2A and Class 1 recommendation, respectively. Iron deficiency in our study is defined by a ferritin level than 100 nanograms per milliliter, or a ferritin level of 100 to 300 nanograms per milliliter with a transferrin saturation of less than 20%. The upper limit of our hemoglobin level for patients included in this QI project was 15 grams per deciliter. However, as one could infer, iron-deficient patients who had a hemoglobin level below this level but who were not anemic, which is the group corresponding to 12 to 15 grams per deciliter for females and 13.5 to 15 grams per deciliter for males, were still included in our QI project. A didactic intervention in the form of a PowerPoint presentation to our residency program took place on the 11th of November in 2024. Surveys sent out to residents before this presentation and after this presentation were used to collect data to measure the success of this intervention. The result of both surveys displayed a significant change in resident behaviors in managing heart failure patients admitted to the hospital. The proportion of residents who believed that the prevalence of iron deficiency in HFrEF exceeded 30% were 45% pre-intervention and 63% post-intervention. The prevalence of residents stating they would routinely order iron studies for patients presenting with HFrEF with 24% for patients with anemia and only 8% for patients without anemia pre-intervention, whereas it was 78% for patients with anemia and 70% for patients without anemia post-intervention. The familiarity rate of residents with current guidelines increased from 3% to 38% after the intervention. The percentage of residents who knew that IV iron was the preferred form of iron in treating iron deficiency in patients with HFrEF increased from 45 to 93%. While 87% of residents knew before the intervention that treatment of iron deficiency reduced hospitalizations in patients with HFrEF before the intervention, this number increased to 96% after the intervention. These results display the effectiveness of our intervention in changing resident behaviors towards a more guideline-oriented approach in managing HFrEF patients with iron deficiency. Of note, a meta-analysis of studies on this matter, including the studies mentioned above, found a number needed to treat of 7 after iron replacement to prevent a composite outcome of cardiovascular hospitalization and CHF hospitalization, showcasing the potential change that could be taking place in our community's cardiovascular outcomes resulting from our intervention. Our future research will be directed towards gathering data from our medical records department to evaluate the change in the rates of resident-ordered iron studies in patients admitted to our hospital with HFrEF and administration of iron to patients that are deemed candidates pre- and post-intervention.